And Jun Young Chang, please.
Hello, I'm Junyoung Jang from Asan Medical Center in Seoul, South Korea. Today, I'd like to talk about endovascular treatment for carotid artery dissection. In this 10-minute talk, I will start with an illustrative case of carotid dissection and then briefly review the epidemiology and pathomechanism of carotid artery dissection. I will go into some detail on the indication, timing, and method of endovascular therapy. And finally, I will discuss the safety of this therapy in carotid artery dissection. A 76-year-old man presented with recurrent left-sided weakness. On awakening, the patient developed transient left-sided weakness that lasted for an hour, the day before hospital admission. Recurrent left-sided weakness developed and lasted for 5 minutes while wearing pants 1 hour ago before visiting the ER. The patient complained of a right-side headache and neck pain, and initial NIHS was 0 on examination at ER. He confirmed there had been no recent head trauma or history of cervical manipulation therapy. MRI revealed right MCA territory multiple scattered infarct and right cervical ICA occlusion. The calculated volume of infarct core was 0.54 milliliter, and the volume of ischemic penumbra was more than 190 milliliter, which indicated a huge diffusion-perfusion mismatch. Although the intimal flap was not observed, tapered occlusion pattern coupled with minimal or no atherosclerotic changes on other arteries and suspicious intramural hematoma on the anterior part of the right cervical ICA with an Hounsfield unit of 78 on the CT scan suggests that dissection was the most likely etiology of the occlusion. Diagnostic angiogram revealed right cervical ICA occlusion with distal ICA and MCA flow reconstituted by ECA collaterals. However, ipsilateral ACA was minimal. A microwire and microcatheter were carefully navigated through the true lumen. A microangiogram was performed to confirm the extent of dissected segment, as well as confirmation of proper microcatheter introduction into the true lumen. To account for the length of the dissected segment, two superimposed stents were deployed. Extracranial arterial dissection accounts for 5 to 22% of stroke in young patients and is the leading cause of juvenile stroke. The incidence of carotid dissection was about 2 to 3 per 100,000 person-years, and the risk of recurrent stroke was low, accounting for 2% during the 3 months follow-up period, with most recurrence within the first 2 weeks. Thrombus formation-induced embolisms at the dissection site are a major pathomechanism of ischemic stroke. This is a simplified schematic illustration of the pathophysiology process of carotid artery dissection. Intimal tear or rupture of the vasa-vasorum leads to vascular hematoma within the media. This can lead to parent arterial stenosis if the hematoma extends toward the intima, or lead to subadventitial dissecting aneurysm if it extends toward the adventitia. Arterial dissections evolve dynamically to spontaneously heal, form a false lumen, develop degrees of or complete occlusion in residual stenosis, or they can form a pseudoaneurysm. A stent can be used to occlude a false lumen or serve as a scaffold to enable co-embolization of the pseudoaneurysm. Potential mechanisms of ischemic stroke can be classified in 2 ways. Most ischemic stroke that are caused by dissection are a result of early thromboembolism. Turbulent blood flow and arterial injury may predispose thrombus formation. Thromboembolism plays a major role in the pathophysiology of ischemic stroke and provides a rationale for antithrombotics in stroke prevention. A minority of cases are caused by hemodynamic compromise, in which the prognosis is worse. Primary stenting may help improve perfusion by occluding the false lumen and restoring the patency of the parent vessel. While antiplatelets or anticoagulants are the mainstay of treatment for carotid artery dissection, endovascular treatment may be indicated in specific circumstances. Acute arterial occlusion, whether extracranial IC alone or intracranial tandem occlusion, with small evacual and large salvageable tissue, may be a good candidate for endovascular treatment. In case of absence of collateral flow, such as A-shaped flow from ACOM or M-shaped flow from ACOM or PCOM to the ICA territory with a flow-limiting stenosis, may also be an indication of stent deployment. Current guidelines suggest that endovascular therapy may be considered for patients with stroke or TIA and extracranial carotid dissection who have definite recurrent cerebral ischemic events despite medical therapy. Emergent thrombectomy and stenting are necessary for acute arterial occlusion with deep channel perfusion mismatch. Urgent stenting may be needed for dissection-induced stenosis with hemodynamic compromise and poor collateral flow. In case of ischemic stroke caused by artery-to-artery embolism, elective rescue stenting may be warranted in patients who continue to suffer recurrent neurological events despite best medical treatment. When performing endovascular treatment for intracranial arterial dissection, care should be taken when navigating the microwire and microcatheter through an occlusion site because the wire and catheter may enter into the fourth lumen. This may cause extension of fourth lumen and rupture of the dissected artery. A microcatheter angiogram should be performed to ensure that the catheter is in the true lumen. Direct aspiration does not require the step of microwire and microcatheter passage over the occlusion site. Therefore, endovascular treatment using contact aspiration as a first line of treatment may be reasonable in the case of extracranial carotid artery occlusion caused by dissection. In general, a self-expandable stent is more flexible and requires lower pressure for deployment. The lower pressure required for stent deployment may reduce the risk of trauma in potentially fragile vasculature in arterial dissection. However, self-expandable stents hold some disadvantages, including foreshortening after stent deployment and reduced radial force. In carotid dissection, the arterial segment that should be stented is sometimes long and requires multiple and combined stents. To avoid interstent arterial dissection, superimposition of stents are required and end-to-end stent implantation is discouraged. In contrast with carotid arterial atherosclerosis, dissected arterial regions are more compliant and are not usually atheromatous or calcified. Balloon angioplasty may therefore not be required in most cases. A distal protection device is also likely not to be necessary. The risk of extending dissection while creating a new intimal flap with this device outweighs the benefit of protecting distal embolization because atherosclerotic burden is usually minimal or absent in arterial dissection. According to the results of a systematic review, which included 31 published reports and 140 patients, the technical success rate was 99% and procedural complication rate was 1.3%, only occurring in 2 cases. One patient had a new intimal flap created before stent deployment and procedure terminated without intervention. The other case had an embolic infarct in the ACA territory during the procedure. However, the patient recovered and MRS at 3 months was 0. During the mean angiographic follow-up of 12.8 months, in-stent restenosis and occlusion occurred in 2% of patients. All of them were asymptomatic. Ipsilateral TIA occurred in 2 cases, both of whom had no ischemic brain lesion or in-stent restenosis. Endovascular treatment for carotid dissection may be safe and technically feasible. However, we should consider publication biases when interpreting study results. In summary, antithrombotics are the mainstay of treatment for stroke prevention in carotid artery dissection, given that stroke risk is relatively rare in the disease. However, in specific circumstances, such as acute arterial occlusion with diffusion-perfusion mismatch, severe stenosis with hemodynamic compromise and impaired collateral flow, recurrent ischemic event despite adequate antiplatelet or anticoagulant therapy, endovascular treatment can be indicated. Direct contact aspiration may be preferable in patients who require thrombectomy. The self-expandable stent, which has more flexibility, which is less traumatic for patients, may be optimal for deployment in carotid artery dissection. As the nature of the lesion is more compliant, less calcified, and less adenomatous, a balloon angioplasty or distal protection device may not be required. Superimposition of stents in case of a long segment of dissection may be more appropriate compared with end-to-end implantation. Thank you for listening.
Presentation, and this time for discussion. Is there any comment or question from the audience? I have a question to Dr. Junyang Zhang. Your case, initially the NIH stroke scale was absolute normal.
Right, yes.
Considering endovascular treatment guideline in large vessel occlusion, I think your case may not be eligible for endovascular treatment. As you know, endovascular treatment in large vessel occlusion, in general, done in more than 6 point of NIH stroke scale. So considering this kind of guideline, I think your case may not be not eligible, and I'd like to let me know in this case, and do you usually perform endovascular treatment, especially in patients with absolute normal or neurological signs?
As you told, usually the large vessel occlusion with minor symptom in this case, we usually perform medical therapy first and wait till patient deteriorate and rescue thrombectomy is usually performed. But in this case, patient was neurologically, the symptom was minimal, but the perfusion status was very poor due to minimal collateral flow from ACA or PCOM. So in this case, the patient had we think that the patient had high risk of deteriorating. So like this case with hemodynamic compromise with minimal collateral flow, we decide to perform early thrombectomy and angioplasty. So we should approach this case as case by case. We should approach, I think.
Maybe in your case, maybe or may not be deteriorated because we do not treat medical treatment. So I think we must be cautious if we see this kind of absolutely neurological normal patients. Okay, is there any question, comment? How about, Dr. Lee, your opinion about endovascular treatment in this patient?
Actually, the second case, which I show you, had also some monocular eye symptoms. So his NIH score was about maximum 1 or 2 or 0. And in our center, we have a similar decision strategy with Professor Zhang. In minor cases, we usually do not undergo endovascular therapy, but when the perfusion status is very poor and have a poor collateral status, and also with the dissection flap is very mobile and has a high chance to occlude the large vessel, then we think about doing urgent endovascular therapy before the patient deteriorates, because if the patient deteriorates, there might be some devastating outcomes.
Okay. No questions?
Dr. Lee, one question from Charles Chan. There is one question. Can I speak up?
Yeah.
Okay. From Dr. Chan. So this question may be to the Dr. Lee, and if there are role for newer antiplatelets in cervical dissection, such as ticagrelor, so especially in patients allergic to aspirin and clopidogrel, poor metabolizers. Do you have any comments for this question, Dr. Lee?
Well, the ticagrelor is not currently reimbursed in our medical system in Korea, so it might be not the initial choice. But and also I do not have any experience. In my opinion, we have already two more popular options, such as aspirin and clopidogrel, and as Professor Zhang told, the mechanism of the ischemic stroke and dissection is usually because of the local thrombus and also the mechanical flap. So, and in opposite to atherosclerosis, the dissection usually heals soon after the several months. So I think there are not many chance to use more options more than aspirin or clopidogrel. Maybe there might be some more, and also might be an option, but it might not be an initial option right now for me.
Thank you.
Okay, because of time limitation, I'd like to move to our next topic. Next two topics